Oh, great. Okay.
Oh, John's joining us. Okay, so looks like we're all back again. So let's go on to the next lecture here, which will be MR and the evaluation of lumbar inflammatory disease. So we've talked about degenerative disease. We'll now talk about inflammatory disease, and then next we'll go to traumatic congenital development, and then maybe later in the year we'll talk about the neoplastic stuff. So let's see, who did the last one? I don't know. Here. Thomas did? Yeah. Okay.
55-year-old back pain, facet injection. Okay. Well, let's see. It's T1 on our left.
So this is left and this is right. They're both
Oh,
T1.
okay. I got you. Okay, so this total effacement of the fat around that, I guess what's L5S1 neural foramen. I guess if they injected whatever they inject, steroids or whatever, into the foramen.
Right
yeah, right there. Yeah, on the right. Yeah.
And here's a post-contrast study through that same area.
Yeah, it looks like it's enhancing.
So you don't really see the fat around the nerve root there. Here are the axial images.
Okay, T1 on our left, and was that a T2 on our right?
Yeah. So what do you think?
Well, it could be blood in there, in the foramen.
Blood? Where do you see blood?
Well, it could be granulation tissue. I mean, granulation tissue.
You can certainly see the replacement of the fats all through this area.
Yeah, it could be scarring.
Higher intensity on T2. Here's the post-contrast study. So what do you think is going on?
Scarring.
Okay. What do you think all this stuff is? You think that's
no? That's not that extensive.
So you think this is scar tissue? Notice that it's continuous with the facet joint here.
Oh, okay. Yes.
And just this diffuse edema.
Synovial. It's synovial thickening.
So this was a MRSA infection. This is all abscess and inflammatory disease from the injection, and this is all an abscess, which we can see through here.
Okay, 46-year-old male with low back pain radiating into both lower extremities. Okay.
This patient had no procedures.
No procedures.
So this was 7/13/11.
Okay.
And see anything here?
So the nerves are kind of like displaced, like they're lower, like the conus maybe it's more down, like.
Yeah, those are just part of the nerve roots lateral and posteriorly. What do you think about this area right here?
Okay, there is some abnormal signal. It's T2 probably.
This is a stir. This is T2. This is T1.
Okay, some abnormal signal at the end plate of the L5 posteriorly.
So what do you think this is? And some disc disease there you can see as well.
So it can be some kind of like degenerative disease. It can be acute injury.
Okay, the patient had increasing symptoms and came back 2 months later.
Okay, so now we have diffuse abnormal signal of the L4 and L5.
Yeah. This is dark. There may be a little annular fissure here.
Look at is somebody saying that this is degenerative disease?
No,
on the first image. There's no involvement of the disc, so I will think of degenerative disease also here, not only infection, but here there's definitely infection. There's involvement of the disc space, diffuse enhancement.
So what do you think this is?
Discitis, osteomyelitis. Yeah.
Okay, so in the past, people talked about discitis and infection, and that it involves both sides. But now we know from MR studies that usually it starts out as osteomyelitis from a hematogenous spread that ends up in the end plates, and you develop firstly the osteomyelitis in one end plate, and then if it's not treated, it then extends into the disc where you get the discitis and then crosses to go over to the other end plate in the other vertebral body. So this is a classic course of really osteomyelitis in the spine. Back in the days when we just made this diagnosis by plain films, almost always by the time we saw it, or we could see it on any imaging studies, it would really involve the disc and both sides of the space, and then you'd get erosions involving both end plate, which is the classic plain film finding of discitis. But with MR now, we can see this much earlier on in its course, and just be aware that this can happen. And if you go back here, usually the degenerative, if you think about the modic 1 changes that we talked about before, they're linear right along the end plate. This is more spherical in its shape. It also is in the classic location for early osteomyelitis. It's really posteriorly, and it's near the pedicle. And that's where osteomyelitis usually starts. So this has a different configuration than the typical degenerative change, and that can also tip you off that this may be something that's not just degenerative. John, did you have something to say?
Well, yeah, the thing is, when we used to get x-rays, it would take almost a week to find out that there's an abnormality in imaging. With the MR, I think, what does it take, 2-3 days? And you can really save on the spine, whereas with the MR, you couldn't. I mean, with the x-rays, you couldn't.
Yeah, with X-ray, you've got significant irreversible changes before it's positive on an X-ray.
It used to throw me off lots of times.
Okay.
Okay.
And believe it or not, Santa Monica is not free of staph infections.
Yeah.
Okay, T1 and T2 sagittal images. It looks like one of the lower lumbar vertebral bodies is hypointense and on the T1.
It's hypointense on the T1 and hyperintense on the T2, which is pretty classic for osteomyelitis.
Here it looks like it has progressed through the disc and into the...
And then here's the follow-up studies here.
It looks to me like there may be a fracture.
Okay.
End plate.
Yeah, this was all osteomyelitis here. And then what's found in the early days of MR, we found that one of the early findings of osteomyelitis on the MR scan, which is fairly specific, is if on the T1 weighted image you lose the definition of the end plate, it's often preserved on the T2 weighted image, but losing the definition of the end plate is almost pathognomonic of osteomyelitis. It was, and then the patient was actually put on antibiotics. They did blood cultures, but it actually progressed on antibiotics. And this patient.
One thing about
abscess.
aspirating the spine and getting cultures done, it's quite common not to find the organism. And so you assume the worst, and you put the patient on a broad spectrum, whatever will bite.
Okay. Next.
Okay, so multiple sagittal images of the lumbar spine, T2 start, T1 and post. So L1, 2 probably, lots of disease at involving the end plates and the disc, which is enhancing on the post contrast. So again, I believe is, and loss of height of the disc. So disc is almost eaten up. So discitis, osteomyelitis.
Yeah, that's another discitis. This was treated with antibiotics, just like John said. An organism was never found, and it went on to degenerative disc disease.
It was very, very frustrating in the old days not to find the organism and go nutty.
And here's another case where we have discitis, and you can see all the inflammatory infiltrate surrounding the disc at that level, and some involvement of the psoas muscles on the left side. Okay, Thomas, or say, I'm sorry, Pablo, what do you think of this case?
54-year-old male with low back pain, fever for several days. And let's see. So we have a sagittal T2 on the top, T1 on the bottom, and looks like there's spinal canal stenosis. Looks like there's some, I don't know if that's disc or probably it's a collection. Could be also like an abscess.
Yeah, it looks
in
like
the case of inflammation. Pardon?
Disc protrusion there, I think, or the extrusion.
This protrusion, okay. So here's it looks like a stir, or is it a post contrast?
T1 facet post.
Facet post contrast T1, and there is enhancement of around the disc, the protrusion. I'm not sure if anterior to maybe the vertebral body was also enhancing in one of the end plates.
Yeah, so this was cause an extruded disc on that side, compressing the nerve roots and in the lateral recess. And they did surgery, and this turned out to be a pus collection, and they grew out streptococcus.
Oh, that was around the disc?
Yeah.
Collection around the extruded.
Yeah, that was all an abscess.
That was all an abscess.
Coming out of the disc.
Could you have that degree of enhancement just with a disc, with inflammation, not with infection?
Yeah, well, I showed that. I don't know about that much, but I certainly showed you several cases where the discs enhance when you have
yes,
without infection. Yeah, Thomas, what do you think of this case?
72-year-old female, back pain, white blood cell count is increased.
Yeah.
Okay. So we have a bone scan and plain film. So on the plain film, there's a loss of vertebral body height at L2, right, and depression of the superior end plate. And then there's increased uptake at multiple levels of the lumbar spine. Okay, ready? So then we have a T1, T2 fat set, and a post-contrast. So there's marrow replacement on the T1. There's edema with enhancement, and the discs, they're not edematous. So it's be osteomyelitis. They did in vertebroplasty.
So, yeah, these are kind of the edges here, and they're at multiple levels. So you always have to think in the back of your mind, maybe some sort of inflammatory spine disease. See this like psoriatic arthritis or something like that there. But obviously we're concerned in the infection category here primarily, vertebroplasty. This is what it looked like. This is 11/2/18, 10/12/2, 10/11. Oh, 11/21/2010, 12/2/2010. This is 2/18/2011. So this is like 3 months later.
Right. So another T1, T2 fat set, and boost contrast. So there's diffuse enhancement of the two vertebral bodies. The disc is hyper intense on T2 fat set, and is effacement. It's like a perivertebral collection. It's also enhancing. So yeah, this looks infectious.
Okay, so fungus was negative, AFB was negative. This just shows when you get disc distraction. These are how commonly you can see that in these different cases. You always get an abscess with Candida, often an abscess bacterial, less so with tuberculosis, even though it's well known for fluid collections. Here we can see progressive disease, and this turned out to be Candida Glabrata when they actually cultured it out. So this was a Candida infection.
Sorry, what is it about this that's
What?
First of all, you said fungus was negative here, right?
Yeah, initially it was negative, but eventually they grew out Candida Glabrata.
Okay, and what is it about this that's supposed to tell us that it might be fungal? I missed it. What, is there something specific about this that tells us it's
No.
fungal?
No, you have to get the organism. There's nothing specific.
One thing for sure, we're going to have a lot more of this pathology in the near future.
I think that's true, especially with antibiotics and antifungal medication not working.
The first place that, when I was in the service in 1964, and the main treatment for us young guys in medicine was treat VD. And we found out early on that penicillin and tetracycline did not cure the problem. As a matter of fact, tetracycline made it worse. And we called all over Washington, and nobody listened to us because we're just a bunch of punks. You know, it took them something like 40 years to realize that GC is not resistant to penicillin.
Yeah, it finally developed a resistance that was widespread.
It used to drive us nuts. We kept the patients in the hospital for 5 days. Wow. And then would switch antibiotics, and somehow these guys got around it.
Okay. Well, why don't we stop here, and we'll pick up here next week. Okay? Thanks, everyone. Thanks, John.
Thank you.
Thank you.
Dr. Cruz?
Yes.
Just want to let you know that next week I'm going to be in a meeting
Okay.
in Chicago, so I won't be